Good afternoon and welcome back بعد العيد holiday. كل عام وانتم بخير. I think this is too dim. Yeah, too dim. لو نور شوي على الأقل الكراسي الخلفية. أيوة جميل. I think this is good. طيب. This lecture will be a subspecialty lecture, and I think this is a series of the anterior segment subspecialty lectures. قد يكون السيكونس حقها متغير, and unfortunately it is late notice. There was a vacant in the subspecialty because of certain arrangement, and this lecture is supposed to be next week, but they pull it to be this week. I'm fine, inshallah. It won't take time and will be up to the point. Today we are discussing two spectrum of diseases mostly related to sclera and its surrounding tissues. As you all know, the sclera is the outer covering layer, and it is relatively avascular, and this is why sometimes it is crucial to know the disease and the etiology and to treat. And both of these are challenging in case of the sclera. Yes, it is an advantage in terms of anatomical structure, but sometimes when it is an inflammatory or infectious etiology, then you will be in challenge. This is a diagram of the sclera, and just remind that the sclera extended back and covered also part of the optic nerve. And here are the area of the insertion of the muscles. And here are important, please make a note of these, because these are usually a weakness of the sclera at the time in the insertion. And also it is a place of immune-related inflammation. Weakness and inflammation mostly occur in the sclera around the insertions and at the limbus. And both of these has and carries a pathophysiology reason. And this is why when you see it in your MCQs questions or exam questions, you need to go back and think why. And if you go and dig more, you will find out that the structure itself is thinner and the immune and vasculature is different. This is why in these areas are the hot areas in the sclera. The layer between the sclera and the conjunctiva called episclera, and it is a thin layer, but it carries some importance because it may be the place of the inflammation and where you need to look and treat. And again, at the limbus, usually this is a place of the conjunctival plexus, and the immune system, most of the immune-related diseases in terms of cornea or sclera will happen at this area. فذلك دائما الBUK, ulcerative keratitis, Episcleritis at this place. فذلك مهم جدا you control the inflammation at this area. Talking of which is the episclera, just a few words about the episclera. As you said, it is vascularized, and it is a thin layer covering the sclera. And most of the time when the inflammation happens, it is mostly self-limiting. Most of the time it is diffuse. Sometimes it can be nodular, and typically stays for a couple of days, couple of weeks, and goes by itself most of the time. لكن أحيانا we give topical weak steroids. في قليل من الحالات we may give non-steroidals for 1 week only, and most of the time it improves by itself. The association with immune or autoimmune disease is limited. This is less than almost quarter or 30% of the cases. Other than rheumatoid arthritis, which is the most common, is gout. Gout is important to check in those patients, خاصة لما يكون مع joint pain or any other symptoms. You need to check the uric acid. If there is no systemic inflammation or any systemic history, usually it would take time. But in case of repeated attacks, or if there is any symptoms suggested of connective tissue diseases, it's worth to do investigations. Back to the scleritis, which is the main bulk of our lecture. When you go and look for the cause of the scleritis when going autopsy in some of the books, find it is necrotizing scleritis. In case most of the time necrotizing scleritis where they get the cadaver eyes or eyes from the death people, 75% or 90% they found out there is a sort of vasculitis, and there is invasion of the neutrophils and mostly T cells. And why we are looking for this? Because if you want to control any disease, you need to know what is the pathophysiology. And in fact, this is the importance of such lectures, which is the subspecialty lectures. You need to know and train your brain, to link between the pathophysiology and the manifestations and the treatment. Right? Sometimes we are successful in doing this, and sometimes we are not because of lack of knowledge. Like with, inshallah, improvement in the diagnostics ability, we will be able to know exactly what is the component or what is the structure that is diseased, and then you can treat it. And if you go back to the natural history, before most of these diseases, we treated with steroid. Steroid can work early in the anti-inflammatory. Now we are more specific, more selective, based on these such studies where we can isolate the diseased limb of the immune system or isolated component or cells. So in these cases, we found out that T cells and B cells can play a factor in the immune cause of scleritis. But how would you classify them? There is a common way for classification. Both of them are valid. Either you classify it based on the etiology or based on the nature of the disease itself. If you talk about etiology, it is an autoimmune systemic association, and here we are talking about a list of differential diagnoses. Most common of them is rheumatoid arthritis, and in rheumatoid arthritis patient, it is almost 10% of all rheumatoid arthritis they may present with scleritis. ولما تعكس الأمور تقريبا 1/3 of scleritis cases is having rheumatoid arthritis. Both of these are usually presented either a presentation or a part of the natural history of the disease. أحيانا the first presenting sign of rheumatoid arthritis is scleritis, and you do investigation. الزملاء اللي they face these cases في الطوارئ أو في general clinic, they prove this, and sometimes patient has no symptoms other than redness and repeated attack of scleritis, and we do the investigation, rheumatoid factor, we found it high, and then you refer the patient to the rheumatologist. And next, patient who's following the rheumatology clinic, and they refer them back to you because of the high manifestation, and it is a scleritis. Wegener granulomatosis is less than rheumatoid arthritis, but it is important etiology based on unfamiliar of patient. And when you talk about the rheumatologist or the internist, sometimes they don't know exactly that Wegener can cause scleritis, and also ophthalmologists sometimes they are not aware. They may find the granuloma in the choroid or in the retina or the scleritis, and they don't link it to Wegener, where they need to do some systemic investigations. And in fact, some of the time, this systemic investigations, the control is life-saving. You will save the kidneys and save other parts of the body if you initiate the treatment early. And we have a couple of cases I knew from my practice and from discussion with colleagues that the patient lost their kidney because they were not treated well. والعكس صحيح. You can manage the patient, they get back to normal when you pick their diagnosis early. Other causes is relapsing polychondritis, systemic lupus, also and arthritis nodosa. All these can cause scleritis. But it is important to dig in the history and do some investigation in those cases. The other etiological factor is infectious causes, which is important, especially in our setting as ophthalmic emergencies. You may have a patient who had surgeries or trauma to the sclera and present with infectious scleritis, or a case that is having, usually classically, they don't respond to immune treatment. And if you do take culture, you will find out that it is infectious. TB can be one of the causes. Herpetic, bacterial, especially Pseudomonas, is an important etiological factor in those cases, خاصة post-pterygium surgery. A patient post-pterygium, think about Pseudomonas, and you need to take culture for those patients and slides. The other classification is masquerade. Mostly melanomas and lymphoma can present with scleritis. And recently we saw a patient before 2 months or so, a patient with referred as suspicious of scleritis and tend to be a lymphoma. But it is one of the differentiating factors. Surgical induced, as we said, either because of pterygium or even retina surgery. Retina surgery around sclerotomies can initiate a scleritis. Again, either an immune-related or an infectious. Both possibilities are there. Other causes is trauma or medications can cause also scleritis. This is a patient, the above picture is the diffuse anterior scleritis. These patients tend to be psoriasis, as far as I remember. The lower one was post-pterygium, and post-pterygium excision found to be Pseudomonas with infectious scleritis, and after treatment, it turned back to normal. The other type of classification is based on the structure that is affected or the presentation of the disease. Episcleritis, we talk about it, we said it's mostly diffuse. Anterior scleritis or posterior scleritis. Anterior scleritis, mostly it is diffuse. Again, nodular can present, necrotizing with inflammation or without inflammation. Without inflammation, we call it scleromalacia perforans, and it is mostly related to rheumatoid arthritis. Posterior scleritis can be diffuse, again, and or nodular. Less likely to be necrotizing, like most of the time it is among the diffuse type, and it is again one of the challenging to diagnose. طبعا أحيانا you may find some suggestive findings in the your exam, the fundus exam. What you will find, Noah? Posterior scleritis, what you will find? Okay, folds. You'll see folds, and sometimes this is indicating there is inflammation back and pushing the retina. Or أحيانا في البي scan, what you will find? Excellent, thickening, and the classic T sign. T sign. What is why we call it T signs? Do you know what is? Sign. Yes, and I think I have one picture of it. Yes. See, like stretching of the optic nerve and obliteration of the surrounding space and giving you a T shape. And it is not uncommon in posterior scleritis to find a T sign of posterior scleritis. طبعا one classic questions earlier, how to differentiate between episcleritis or conjunctivitis or uveitis or scleritis. طبعا differentiation can be يعني list of things. Don't think in one test will be enough to tell you which one is which. Like it is a collection of sort of points to tell you. In case of how can we remove this one? Okay. Drag it. No, cannot be. ممكن نشيلها بس هذه. The scleritis and episcleritis. طبعا let's يعني get rid of the easier one, the conjunctivitis. Tell me what are the things that may differentiate conjunctivitis from episcleritis or scleritis. First, laterality. Conjunctivitis mostly bilateral. If you see bilateral redness, mostly it is conjunctivitis. طبعا ما هو دائما, لكن mostly it is conjunctivitis. When it is associated with itching, tearing, discharge. Mostly this is something related to the conjunctiva. Contagious, somebody has redness in their house or in the school and get that the same. This is mostly conjunctivitis. And here, if you put phenylephrine, the phenylephrine اللي موجودة في العيادة أو في الطوارئ 2.5, mostly the conjunctiva will improve. This redness will disappear. Then it is mostly superficial. فخلص الحين conjunctiva, conjunctivitis will get rid of. يبقى the more critical differentiation between episcleritis and scleritis, which is tricky. Even for us as experts, sometimes we don't know exactly if this is episcleritis or scleritis. لكن pain in scleritis, it is usually dull, aching, and more tender. I touch the eye, patient will jump. But that is mostly scleritis. Systemic association, we said it is more with scleritis. In the sclera, you will find some edema. Inshallah, one picture that I can show it, or thickening. This picture can show more. Or if there is an old attack like this one, thinning and exposure to the choroid, this is indicating this is mostly a scleritis rather than episcleritis. Phenylephrine, if you able to get the 10% phenylephrine, mostly it will improve the episcleritis, but it will not do anything with the scleritis. But again, it is not that test that will give you exactly you are dealing with a certain disease. Like, again, it is collective of things. Again, when you work up those patients, you need to ask complete history and review of the system. You need to initiate some laboratory investigation, especially on the repeated attack or unclassic presentation. And we said about rheumatoid factor, ANCAs, and ANA, all these can help. This is mostly the granulomas that we are talking about. Okay, any question in terms of presentation so far? هل في سؤال؟ Any question? Clear. تفضل. Yes. Okay, excellent question. طبعا mostly infectious scleritis is, let's face it, is rare. It's rare. If you have trauma or previous surgery, this is it increases the possibility in it called infectious. If you're talking about a patient who has no trauma and no other disease, mostly we treat it as an inflammatory or immune related. The classic history or classic scenario, the patient is treated with immunosuppression, no improvement. Changed from non-steroid to steroid, no improvement, stays as it is. Now it is the time that you need to take a biopsy, and it's a bit invasive to take a biopsy. And there are some reported cases, and we have treated cases that we took a biopsy from a lump or enlargement of the sclera and tend to be TB granuloma. TB granuloma, yes. Mostly no, yeah, because it is covered. إلا لما تكون necrotizing. لما تكون necrotizing, it can give you. This is why I'm saying it is after it is post-surgical, deal with it as mostly it's infectious. And in fact, we in our paper that we published, I will show it in a minute. We recommend when you have a patient post-surgical to deal with it as infectious until proven otherwise. بينما العكس مع immune related or classic scleritis, mostly the infectious will be at the bottom of the differential diagnosis. Okay, so how would you manage those patients? If the patient comes with unilateral scleritis, diffuse one, this is usually the classic, you give them non-steroidals. طبعا one important thing to non-steroidals, ما نعرف انه كثير انت تاخذه as حتى painkiller. People, what is the risk of non-steroidals? If you know your nephrology colleague ولا أحد من الباتش راح nephrology, they are usually irritated when you say non-steroidals. They don't like it. Why? Yeah, they face cases that they have renal toxicity because of these simple non-steroidals. So don't take it as a simple medication. It can catch. So that you weigh the risk and benefit. And if such, you need to follow those patients closely and to know what is the renal function. For some patient who is مثلا diabetic and has borderline renal function, maybe the non-steroidal will not be the best treatment. Yeah, it is a message that to tell you, even simple medications can cause complications, but don't take it lightly. بعد oral non-steroids, if there is no improvement, then you can go for systemic steroid. Systemic steroid can be oral most of the time. Mostly in scleritis, we are less aggressive than uveitis. We give half dose. Somebody who's 70 kg, we start with 35, and we taper it over weeks. And most of the time, they will improve. If it recur, طبعا احنا نتكلم عن an absence of systemic association. This is an idiopathic scleritis. If there is a systemic association, or the patient didn't respond to first systemic round steroid, then it is the time to give or other immune sparing or steroid sparing agent, immune suppressive treatment. And most of the time we start with methotrexate or Silset. These are usually the medication that we started with as of now. And we will talk about في نهاية المحاضرة. There is now changing sometimes medications based on the presentation. And again, if you think about systemic disease, you need to treat it with good collaboration with your colleague, the internist, and to know how to treat and how to taper those medications. طيب in terms of surgical, طبعا نتكلم عن surgical management أحيانا يكون needed when you have necrotizing or perforated eye, and here you need to do tectonic graft plus controlling of the inflammation. And if you are planning to do cataract surgery or glaucoma, which is managing of the complication of the scleritis, you need to deal with it in a more controlled fashion, and you need to plan it well in terms of controlling the inflammation pre-operative and intraoperative to be less traumatic, and the post-operative you need to manage them closely. Talk about complication. These are the most common complication, scleral thinning, and this is what we want to avoid. يعني الزملاء اللي يعملون في general hospitals, they are facing some cases of rheumatoid arthritis, young ladies with thin sclera, and cosmetically is not acceptable, and yet they are having controlled disease. This is too late. But this is why you need to prevent the destruction of the thinning of the sclera in terms of cosmesis ولا حتى risk of perforation. فدائما يعني you need to initiate the proper treatment at the proper time. Delaying the treatment will cause more damage to the structure, which في كثير من الأحيان is irreversible. فدائما weigh things, risk and benefit. أحيانا نتحرج يعني I don't want to take the example of non-steroids and to avoid treating those patients. لكن it is the treatment you can go up to cyclophosphamide or up to rituximab when the patient is in need. لكن don't delay it looking for the complication or whatever. Glaucoma and cataract also among the complication, either because of the disease of the inflammation or based on the treatment we give steroid. Ischemia also reported, like it is less likely. Yes.
I have a question that, for example, the sectoral diffuse scleritis, you give NSAID.
Yes.
And then you want to follow up to assess if there is improvement or not, and to stepwise approach. How do you give the follow-up usually to assess the response to that?
Mostly you give 1 week to see, and you will give 2 weeks or 3 weeks before you decide if there is a failure. Like mostly classic, what you need to hear after 1 week. The patient symptomically improved, will no more pain, is more comfortable. The redness is still there, it's fine. Like if after 3 weeks the redness still the same and still there is active inflammation in the sclera with edema, now it is also a failure of the treatment. The one important studies series is the systemic immunosuppressive treatment trials or study group, and they look all immune related diseases. One of them is scleritis, and they found out the cyclosporin, methotrexate, and Silset are relatively the same. Cyclophosphamide is more, لكن أعتقد that was يعني in 2012 the study was appearing. By that, now I think it is not changing. But still, the methotrexate and Silsip are more safe, and it's good to control those patients as well as steroid-sparing agent. In our hand, the Silsip mycophenolate mofetil is one of the good treatment for those patients. This is one also famous study in the field of scleritis by Doug Jab and associate, and they looked to the disease and laterality, and they found out that it is the diffuse anterior scleritis is the most common. The posterior scleritis is the more destructive, and the immune suppression are needed in most of the necrotizing and posterior scleritis. And it is common in female mostly. This is again a major review about scleritis. You can go back to it. And during the time, maybe 2015, we did a study. It was shared between King Abdulaziz and Kekash. At that time, Dr. Mohammed Al-Bargi was the senior resident at that time. And this is one of his theses. And they collected the patient of scleritis in both institute after the exclusion criteria, inclusion criteria. And they found that non-necrotizing scleritis or anterior non-necrotizing is the most common presentation in our scleritis cases. And most of the time, they presented with normal visual acuity. The posterior scleritis and bad scleritis usually present with poor visual outcome, and also they end up with poor visual acuity in the posterior scleritis. Most of the anterior non-necrotizing stays as it is. It will not affect the visual acuity. In that series, we found out most of the cases was started with oral steroid, which is still the current practice. Non-steroidals was started in 40%. Subconjunctival injection was done in one case only. And that was, at that time, sort of acceptable, but nowadays it's not as acceptable as before. And now if you do the same study, you will find out subconjunctival steroid as raising. It is not any more contraindication. Before, when you go to the board exam, you said subconjunctival steroid use, they will say this is a red flag. Now it is not. There is a clear indication for subconjunctival canalog use, especially when you are dealing with non-necrotizing, a unilateral, and you rule out infectious. This is a good combination to give subconjunctival. And we have patients, they are extremely happy and well controlled with subconjunctival, one injection of triamcinolone. Treatment of immunosuppressive, again, I'm sure now the names of the medication are changing based on raising the less toxic medication. Like at that time, cyclosporin was among the treatment, which was the highest. Silsip was also raising, but nowadays I think it's all just been Silsip and methotrexate, and maybe to lesser extent the rituximab for the last 5 years. Complication of that series, which is in our region, is anterior chamber activity, which is not uncommon to find some AC reaction. How would you differentiate? Is this a mainly uveitis or mainly scleritis when you see the primary cause of the inflammation or the more hot or toxic on the tissue of the eye? If you find it in the sclera, it's mostly secondary uveitis. If it is the opposite, mostly it is uveitis with associated scleritis. Most complication was the cataract, and again, we said in the cataract you need to deal with them as you are dealing with uveitis cases. You need to prepare the patient preoperatively, control the inflammation for at least 3 months, and when you want to do surgery, phaco will be much better than doing scleral tunnel phaco or a small incision or ECC. Systolic macular edema is presented in most of the scleritis, and the T signs, we found that it was present in 60% of the scleritis. But this is an important sign to look at, especially when you see a patient with fall. It can for indicating scleritis. And that study, we concluded that The visual outcome depends on the subtype of scleritis. The most common type of scleritis in our population was anterior non-necrotizing scleritis. We found that the mostly female patient was presented more, and based on the association between the infectious scleritis and previous history of ocular surgery, in that study we recommend any post-surgical cases presented with scleritis required to undergo thorough microbiological workup to exclude any infectious etiology. Talking about the treatment, this is a relatively recent study about rituximab treatment in either uveitis or scleritis. And in this study, they found out the rituximab is giving an excellent outcome in those patients with non-infectious etiology. I'm saying to you now it is a rising treatment in the field of scleritis, which is the rituximab, which is controlling it. What control rituximab? CD20, yes, which is mostly the B arm of the immune system. Okay, this is a patient. I can show you some of the examples of cases that we saw in our clinic. This is a patient post-pterygium excision. This is when the patient presented. You can see the thinning and the necrosis. And here again, this is the area of vasculitis and necrosis, because there is no vasculature and the eye this area is exposed, it causes more thinning, cause more inflammation. And that was an infectious, and we control the infection and we treat the patient with ointment mostly to cover for lubrication. Patient in maybe 2 days, يمكن عند 17 12 وهذه 15 12, and just in 2 days that one is disappeared. And you see how quick. ليش؟ لأنه there's good vasculature at this area. The Episcleritis and the conjunctiva will cover once you control the infection and you control the inflammation. ذلك using of mitomycin post-pterygium, I have some reservation on it. And that will cause more ischemia. In my opinion, and also from the literature, I mean, this is not a 100% convincing assumption. The autograft, if you want to do something for those patients who has pterygium, do autograft. Like in doing bare sclera with mitomycin application, I don't think is something worth the complication. Like in the thing that we know at post-pterygium, if you want to do autograft, will be the best to do. Like in mitomycin, still I have some reservation. Personally, I don't use it. We saw cases. This patient has mitomycin. The other thing that post-pterygium that may happen incidentally, that using non-steroidals drops, خاصة البروفين drops, non-steroidals, not the حتى ocular. And I think Dr. Mohammed Abusir is collecting cases. Think of a series of 6 or 7 cases. They had melting in the cornea or in the sclera because of the non-steroidals. 5 of them was topical non-steroidals, and 1 of them was oral non-steroidal. And all the possibility was excluded, yet the non-steroidal was blamed. فذلك topical non-steroidal is not something that you need to use, خاصة في الحالات اللي يكون فيها irregular surface, either in the patient themselves or in the surgical intervention. If you leave the patient with Dylan effect or bare sclera, or any patient that has any thinning of the sclera, you give non-steroidal, that will cause the worsening of the situation. This is the patient who had the surgery. Yeah, the picture before had the patient who had the toilet. Yeah.
This patient, how frequently you apply the ointment? And here it seems like it's open flow. So
yeah. No, it was not open at this time when we did the fluorescein. It was not leaking. And tell you the truth, the response was so quick that I was questioning the patient. Come يمكن الشباب اللي يعرفون اني احيانا يصير patient يمكن اليوم ما اشوفكم في خالد وارجع اشوف اليوم. So this is the same patient or no? He improved immediately, and this is why I think it's the controlling of the infection, and it was Pseudomonas, and we know Pseudomonas even in the cornea had good response immediately. Cyanide more virulent, but it had good response, and this was in 2 days, and the ointment was QID. Give QID ointment. Then again, you can Dr. Wa'il معنا, you see patient that when you shift them to ointment, then the ointment stays more and protect, also give more lubrication, but give you dual effect. In أحيان كثير من الأحيان it's not only the infection or the inflammation itself. This Dylan effect is يعني we underestimate, and if you treat it, usually things will go back to normal. This is a patient who we said has skin manifestation. He had to be psoriasis with the investigations. This is why you said to you when you can find like a swelling or edema and the blue around it. This is a scleritis, no doubt. It's not a nodular episcleritis. It's a scleritis, and most of the time, this is a patient. This patient, the way I bring it, because the patient was, I think she was a rheumatoid arthritis disease patient, was controlled systemically, and the rheumatologist was not in favor of giving any other treatment, saying everything is fine, for which we give the canalog injection, subconjunctival canalog, and she improved. Where I will give I will not go to the area of the thinning or more inflammation. I will go to this area, one half of the dose here and 1/2 dose is here. And we were following the patient. After 6 months, you can see the deposit of the canalog trimicin. A patient respond plus the systemic control. فأنا أقول أحيانا subconjunctival will be enough to give the treatment. I can be also supplemented. This is the patient who said we are suspicious of lymphoma. This can be presenting as a lymphoma. This is a patient who had retina surgery, and you can see there is an area of necrosis around the sclerotum is pleasant, tend to be a Pseudomonas and controlled with treatment. This is a patient, interesting case. We are still, until recently, I'm following him. He's a young middle-aged patient who went to multiple hospitals. First, presented to the emergency with a granuloma subretinal, or people, they were thinking it is a tumor, melanoma. Investigation done, patient lost follow-up, went back, investigation done, and was not looked at. Went to come to our emergency there in King Abdulaziz. And when we do the investigation again, tend to be Wegener granulomatosis. After which, طبعا, he presented with us with more symptoms. خاصة كان creatinine urea was high, and he was starting to have renal failure. When we complete the picture, tend to be Wegener, admitted, treated, controlled the eye disease inflammation, and left with cataract. And then we did for him cataract surgery, but after rituximab. And these, I think, among the earlier cases that we treated with rituximab. And he was controlled well for now. We did the surgery in both eyes, was fine, back to function, back to work. And آخر مرة شفته يمكن قبل سنة وكذا كان he was planning to go for renal transplant. Saying طبعا we were a bit unlucky, or he was unlucky that we delayed the diagnosis for a couple of months. أعتقد إنه واحدة من take home messages for us and for you as a team in the emergency. When you see a patient, you do the investigation, you need to look to these investigations. And we need to retrieve the investigations back that he presented with. There was a C anchor. Nobody looked at it. And we reported this case. As I said, it was earlier using rituximab and cataract surgery. It was uneventful. In conclusion, scleritis is a challenging disease to diagnose and to treat. When facing patients with scleritis, one should have detailed medical and surgical history. Investigations, when needed, should be tailored according to the case. Treatment should be specific and safe, yet efficient. Diamond, this is a gray zone patients are not comfortable, خاصة we as ophthalmologists, and we are not comfortable to deal with these toxic medications, the rituximab. If not, in most of the hospitals, and even in your relation with a colleague from rheumatology or from medicine, they can help you and help the patient. But don't deal with the patient as a case. You need to deal with the patient as a whole. You need to treat them well. Regular and close follow-up of those patients is crucial to judge the outcome and to prevent complication, either from the disease or from the treatment that you are giving. And by this, thank you all for